The following episode is brought to you by the American Urological Association.
Good evening and welcome to AUA's The Surgical Management of BPH and Updates from the AUA Clinical Guidelines live virtual course. We strive to offer outstanding educational courses and greatly appreciate your evaluations and general feedback so that we are able to continuously improve our programs. Evaluations are very important to us. Course evaluations and CME credit will be administered electronically on the AUA University immediately following the live webinar. As we at the AUA continue to develop virtual education that meets your needs, we welcome your feedback regarding both the content and format of this activity. All persons in a position to control the content of an AUA educational activity are required to disclose any relevant financial relationships with any commercial interest. Please visit AUA University to view Faculty and Education Council disclosures. The AUA would like to thank Olympus Corporation of the Americas for providing an independent educational grant in support of this webinar. Finally, I'd like to extend a special thank you to our course director, Dr. Lori Lerner, for her time, talent, and expertise in developing this program. I will now turn the program over to Dr. Lerner, who will lead us in our knowledge assessment and introduce our faculty. Dr. Lerner?
All right. Well, here we are. So the activity goal, you can look this up on the AUA University. It's also posted there, but we're launching an educational initiative for those who are interested in the treatment of BPH. So take a look at the AUA University so that you can see if you're interested in this initiative and reading more about the different educational interventions. Okay, so the learning objectives, I would encourage you to look at them. We're not going to go over them in depth, but the bottom line with this session for today, what we're really excited to talk to you about is diving a little bit into what we believe the role of the AUA clinical guideline is and get some information from our panelists in terms of how they use it. Look at some of the evidence base for some of the technologies. Obviously, it's quite broad. We won't go into all of them, but we will talk about several of them today and how to interpret some of those clinical results in the context of patient experiences and other treatments, and how we sort of think about different types of treatments that are available in their mode of action, as well as some evidence surrounding that. I'd like our faculty, in which I'm very excited that everybody was joining us today. So the first of our faculty, going alphabetically here, Dr. Mandeville is a urologist in Burlington, Massachusetts, and is affiliated with Lahey Hospital and Medical Center. She received her degree from Tufts University. She's been in practice for more than 20 years and has expertise in treating kidney disorders, and particularly stones, and holmium laser enucleation of the prostate, did a fellowship in enucleation, and is one of my partners here in Boston. Dr. McClure comes to us from Weill Cornell. He has a unique training background in that he is not only a urologist, but he is also a board certified radiologist who's fellowship trained in vascular and interventional radiology. So he has expertise in imaging, image-guided therapy, and minimally invasive treatment of urologic disease and prostate, so prostate artery embolization. Dr. Jared Teo is currently an assistant dean and associate professor of the Faculty of Medicine at the Chinese University of Hong Kong. He is up very early, so thank you very much for joining us very early in the morning. Hope you have a lot of coffee. He is also the director of the Urology Center and director of robotic services. So he's an oncologic surgeon, but he also has expertise in benign conditions, especially BPH and aquablation. And finally, Dr. Carla Witzke is a general urologist in private practice in Michigan. She operates out of Mid-Michigan Medical Center in Mount Pleasant. She treats a wide variety of urologic conditions in both men and women, and is a high volume user of the temporary implantable prostatic device. So thank you all very much for joining us today. I'm very appreciative of your time and partnership as we've put together this program, which is going to be great. I'm pretty excited about it. So we're going to start here by talking for the first segment about the proper application and role of the guidelines. Did I advance that one? Can we go back? All right, bear with me, team. This is exactly what we have all talked about here in terms of managing slides. Okay, so what I think is important to understand about the guidelines. So different countries have created different sets of guidelines based on the methodology that they chose to use. For us with the AUA, and we first initiated the guidelines in 2016, the panel first came together in 2016, and we focused initially on the surgical management. And we put the first publication came out in 2018, and then there was so much happening in the surgical world, which of course is part of what tonight is about, that we did a whole bunch of amendments. And then with the medical management, the whole thing came out in 2021, and we've already had another amendment since the 2021 that came out last year. And I think understanding the methodology is really vital in terms of appreciating how to put everything into context with the AUA guidelines. And one of the things that I like to share with everybody is that we stated that the goal of the guideline is to provide a useful reference on the effective evidence-based surgical management and medical management of male lower urinary tract symptoms secondary to benign prostatic hyperplasia. So the evidence base that we used was looking at clinical control trials and randomized control trials that were published and indexed after 2007. So with each amendment, we expanded that out from 2017 to 18, 19, and so on. And then the data that we utilize for these statements are based on what the panel, which was a diverse group in the panel, felt were acceptably performed RCTs and CCTs. But in order to put everything into context to each other, we had to pick a common denominator. TURP was what was used, or sham. So we had studies that were based on what we were able to find of publications that actually related to TURP or sham. So when we think about that, it's important to keep that into context. So if it was a trial that was against something other than TURP or sham, it was not used for generation of the actual guideline statement. That said, it could be within the supporting text in any way we wanted. So we were able to pull in the supporting text to pull in any data that we wanted that we felt was important and valid. So I always encourage people to go in and to actually look at what was stated afterwards. And if you get onto the website, you click on the guideline, it gives you the supporting text. So those give a little bit more granular information and can pull out other things. I wanted to ask one of our panelists here, how do you feel when you're utilizing the guidelines, and like in what way do the guidelines, or do you find them helpful for you? Dr. Mandeville.
Okay, let's see. Can you hear me?
Yes.
Okay. I think the guidelines are important, particularly when deciding what operations are best for patients. I think this is where you can get things wrong and not do the right operation for people if you don't know the size of their prostate, if you don't know the configuration of their prostate. And so I think the guidelines that talk about making sure you have appropriate prostate sizing prior to going into surgery is probably one of the more important things in the guidelines, so that you get the right operation for the right person, or at least give them the right options that work for them. And so I think that's probably one of the key components that I use in my practice every day.
Dr. Witzke, so in private practice, and we certainly see, so I work at a VA hospital, so my patient population is quite different. We all on this panel have very different patient populations. But in the private sector, with a lot of direct to consumer, messaging and advertising that comes out, do patients come in to you? And of course, they don't know anything about the guidelines, to come in and say, this is what I'd like to do. Do you use the guidelines in how you think about things in terms of going back and referencing that?
Yes, yes, I do. And just as Dr. Mandeville said, I think it's really important when patients come in to use those guidelines, understand the size of the prostate, and really kind of help patients understand why they may or may not be the right patient, or I should say their body is not the right, their prostate's not the right size to have a procedure done. And when you explain that to patients, usually they'll understand that really you have their best interest in mind, and that you're just trying to do the procedure that will suit them. One of the things I was going to add was to adding some more questions. Behavioral modifications are really important when you're going through the guidelines, especially nocturia, making sure we're not missing something like sleep apnea so that we're getting good results with patients, and just really going over a great medical history with them too, when deciding on what type of therapy is important for them. Yeah.
Yeah, and actually that's a perfect way to end this first segment, because I will tell you when we created the guidelines, we focused on, you'll see, we're going to flash into that in the next slide, but we created algorithms, for people to follow. But when it came to things like OAB and nocturia, we've referenced other guidelines. So we had a lot of discussion about that. And, we've been asked about that. And certainly during my time as chair, how do we pull in, like, an organization like the AUA that has multiple different guidelines? How do you pull in different groups of people that created their guidelines and meld them all together into one when those lines do get a little bit blurry? And I think that's some of what we've talked about, and the guidelines do mention at the end, about future directions. And those are some of the things that are definitely, we're getting more and more understanding about the physiology of the bladder and how it responds to obstruction from BPH. But you're absolutely right. In terms of, we know that there are other things that could play a role that may not have to do actually with size, may have to do more with compliance or elasticity and some of those other things in nocturia for sure. So absolutely, those are areas for us to grow things in our future. So you guys segued into this beautifully. So some of the things to drive home in this next segment that we're going to talk about is these particular statements. So we all say in urology that a post-void residual, we all think everyone should do a post-void residual, but not everybody has a bladder scanner in the location that they are, right? So you may or may not have it where you've seen a patient, but we do think that it is an important part of assessment in terms of following a trend. We cannot say that there is a particular number that should make somebody be alarmed, but it is definitely, something that we should follow the trend. Uroflows are the same way, but we can't tell everybody you have to have a uroflow when they just got off the bus and they went in and went to the bathroom. You're not going to be able to get one. So what we want is to say, we want you to think about getting a PVR and following that trend. We want you to get a uroflow and follow that trend, particularly if you've done an intervention, to see how that changes things. And pressure flow studies, either invasive or the non-invasive pressure flow studies, those are ones that we say, if you have some diagnostic uncertainty, then that is definitely, you should consider, getting more information to help you. So looking specifically at that, we talked a little bit, Dr. Witzke, already about the algorithm, but so Dr. McClure, I'm going to ask you, when you're thinking about, you're an interventional radiologist, you're double boarded, how does imaging or understanding the size or shape of the prostate influence the decisions that you have when a patient is sent to you, right? Which modalities should urologists be offering, or do you see patients that are sent to you that you say, maybe you should do something else and send them back to the person who referred to you?
Yeah, I mean, size is critical when evaluating patients for PAE. And oftentimes, to your point, people will come in wanting a specific procedure because they hear that you do it. And I think the guidelines are actually a great way to explain to them that this may not be the best procedure for them because there's other options. And with regards to prostate artery embolization, size really does matter. If you have a small prostate, less than say 60 or 50 grams, then those patients aren't likely to do it as well. So if they haven't had a truss or an MRI, then I think it's important to get that. The other aspect of prostate volume or prostate shape is the presence of a median lobe. That's something that we pay attention to. There's early literature to suggest that median lobes might not do as well, but it suggests that they just have a rockier kind of post-procedure recovery, and their outcomes tend to be similar. But if you have a large dominant median lobe, and it's something you have to be cognizant of when you're doing the embolization to make sure that you're seeing that on angiography. So there's definitely a role for understanding the volume and the shape of the prostate too, just when you're planning the procedure itself.
Yeah, for sure, for sure. And I think that is, we've gotten so much more granular in terms of what we've needed to do in that, because there are just so many technologies. When there was only one or two, some of that didn't matter. Dr. Teo, if a patient comes in with an indwelling catheter, like, so they've got a catheter, does that affect your decision-making, or is everything still on the table that it would be if the patient didn't have a catheter in place beforehand, or do you evaluate that patient a little bit differently?
Yeah, certainly. I think, we have so many different types of treatment. It's often the balance between the degree of invasiveness versus how radical is your treatment in terms of efficacy. So certainly, say for patients with smaller prostates, then we might think about doing resume urolift. But if the patient has retention of urine or even obstructive uropathy, then I would be more cautious in offering these options and probably would offer more radical treatment like TURP. And for bigger prostates, then certainly TURP, whole lab aquablation, these are good options. But again, if it's a very big prostate with retention of urine, then obviously we might lean towards whole lab. In order to have a good immediate recovery in terms of relief of the catheter as well as long-term efficacy. So I think these are the things that we must take into account and in order to have a more personalized treatment option.
For sure, yeah. And, we'll go into this a little bit. This was going to be into the next segment, but you know what we're going to talk about here, because I see a lot of questions in the chat that are asking about that. And we are going to get into it a little bit more. But I'm just looking at my script over here, everyone, and saying about understanding bladder function. Dr. Mandeville, just quickly, what do you think about understanding bladder function? So looking at some of these chats that people have put in there and sort of what we're thinking about, and we talked about, urodynamics. When is it important, and when do you think you really need to understand that?
So for me, I've actually significantly decreased the amount of urodynamics I do in my practice. For everyone who came in who I had concern for hypotonicity, I used to get it because I used to think that maybe they would fail a procedure. But now in the setting of enucleation, and the data really does show that even if patients have hypotonic bladders, and I'm talking 0 centimeters of water for a detrusor pressure when they have their urodynamics, they still void, and some of it's gravitational, but you'd be amazed how many come in and they have a flow rate of 30 despite having a hypotonic bladder and they empty. I tell those patients, look, we can do a urodynamic study. If you want to be without a catheter or CIC, this is what we have to do. And there's the smallest infinitesimal risk that it won't work for you. And you may still need to catheterize, but if you want to be without one, I don't need the UDS data to support going forward. Where I do find UDS helpful is for the people with very severe storage symptoms. Those patients, I worry about their capacity. I worry about their compliance. I worry about whether I'm going to put them at a substantial risk for incontinence post-op if they have 110 cc capacity bladder and poor compliance. Sure, we can get you without a catheter, but it may make your life worse in some ways. And those are patients who I may, depending on what their urodynamics show, consider intraoperative Botox at the same time as enucleation of the prostate. And those are patients who also, and I would say if you're going to do UDS on someone with a chronic catheter, it's sometimes a good idea to see if you can put them on a flip flow to get them to cycle their bladder a little bit, because sometimes the UDS will show that they have this bad capacity or bad compliance, but it's just a fact that their bladder's been so decompressed. So for me, really much more minimal use of UDS, and mainly for the severe storage symptoms is how I use it in my practice.
Yeah, and I would say this is our good segue into the next one, and looking a little bit in the chat. Somebody had asked about Urocuff. So guidelines actually are not like differentiating between types of urodynamics. So the urodynamics in the AUA guidelines is all comers. It's talking about both invasive urodynamics and non-invasive, which should include Urocuff. So just so you know, and we will try to answer some of those questions in the chat as we go. But I think that what Dr. Mandeville said and what Dr. Teo said is really important, is making sure that you're communicating the right expectations to patients. So they may be trading one problem for another, or they just need to understand. And so one of the things that we really wanted to drive home, as I alluded to before, is this idea of evaluating patients again after you've done an intervention. So whether it's a medical intervention or whether or not it's a procedural intervention, we think that you would see them back, see how they're doing, see how they respond, trend that PVR, trend that flow rate, get an idea of which direction they're going. And also, it's good for you to track your own results. So, Dr. Teo, how vital is it for urologists to track their own results, both objectively with that flow and PVR after you've done something, as well as reevaluating patient approaches and selection?
I think it's very, very important because clinical trial data and your actual real-world results can be very different. The patient selection can be different. And it's also important not only to learn about the final outcome, but to learn the recovery process and how they actually improve with time is very important. And secondly, although we often follow the inclusion criteria and the trials in order to select which patients to undergo which treatment. But then I think a 30-gram prostate versus an 80-gram prostate can be quite different as well. So it's really a continuous process to learn about the minor or the small details on, for example, prostate size, prostate morphology, the flow rate results in order to really select the most appropriate treatment. And of course, with continuous assessment, then you also can fine tune your technique in order to have the best results in the future.
Yeah. For the statistical analysis for the guidelines, there had to be an IPS difference of at least 3 points and a quality of life difference as 1 point to show that there was efficacy to be included in the guidelines. And so the IPSS is another important component of what we need to follow when we're seeing patients back, to seeing if we've done an intervention. Now, this is when we talked about this, when we have these. Okay, there we are. Dr. McClure, how often do you counsel a patient regarding a secondary procedure or a return to medical therapy? You focus a lot on PAE. You have this unique thing, but what do you say to patients? Like, how do you talk to them about this after PAE?
Yeah, it's a great question because there is some uncertainty about the longevity of PAE data. And when you see a patient, you counsel them, the key aspect, for at least for prostate artery embolization, that you want to follow them in their follow-up, like to your point, is their IPSS improvement. So if patients have a quick recovery and a notable IPSS improvement within 6 months, then you know that the PA worked. And if at 3-5 years down the road they have recurrence, then you can proceed with a repeat PA if they're interested in doing that. But if you don't see the robust improvement that you expect early on, then a repeat PA really doesn't make sense in that situation. Then those situations, it makes more sense to refer, either put them back on medical therapy that they were trying to avoid, or talk to the urologist to talk about different treatment options. So it's really kind of the timing when that recurrence happens. So if it's an early recurrence or the symptom improvement isn't as robust as what you'd expect, that's when you suggest kind of looking at other options. If it's been several years and they have, slow return, then you can start adding medicines back again, or you can treat them again. And the PAE doesn't preclude you from having these other procedures done. There's many studies and many abstracts out there that have shown that PAE doesn't really make any surgery or any minimally invasive technique more challenging. And to that aspect too, prostate artery embolization after a hole up or after whatever you have, if it's recurrent hematuria or anything like that, it's not more challenging a procedure for us to do from that perspective as well.
And I think that this is the idea, is that, it's important that we're at least communicating that to patients, because the thing is about these studies and what the FDA requires is that you report some things. It doesn't actually say what people have to report. And what we found in the guidelines when we looked at these trials, that retreatment rates are really influenced by the duration of how long they followed somebody. Do they follow them 12 weeks, 12 months, 3 years, 5 years?
Right.
And how complete it is. So, this does make it a bit gray, and we're not really comparing apples to apples. That is one thing. So as we segue into these pivotal studies, Carla, Dr. Witzke, you're going to bring us into this. If you have a patient who really wants something, we touched on this before, but the pivotal studies really sway them against that, and it could put them at risk for another procedure. Do you quote some of these studies, or do you feel that patients respond to some of these pivotal studies? Do the guidelines help you in that counseling for those patients?
So yeah, I think that it depends on the patient, first of all, and bringing things to their level. So some patients, I do think, especially if we're trying to really steer them in a direction when we know that they are not a candidate for minimally invasive procedures, their prostate's too big. And so using this data that we have is helpful for patients to make decisions. So I do find it helpful for the right patient, but some patients do come in with preconceptions, and it's very difficult to convince them otherwise.
Yeah, and there's a question here that's made that oftentimes patients ask about outcomes and failure rates and retreatment rates. So you will see, and actually I have been approached about this too, about this idea of real world data, right? So real world data is a big thing right now that we're talking about. I didn't really had talked to the panel about this before, sort of freelancing here, but that's the idea, is that when we are looking at pivotal trials, and how they've selected them, it may not reflect some of the actual real world of what people are doing out there, and if they're actually following the guidelines and the size recommendations and things like that. So, looking at some of these questions in the chat, patients will ask about retreatment rates and failures. And the truth is we don't actually know that in such a way, but there are more and more people publishing on that. But those can be harder to fund. Like, industry doesn't necessarily want to fund something or pit a whole bunch of procedures against each other, because I would think they stand to lose that. Now, some of them may be very willing to do that, but getting funding and research grants and everything is really challenging. So I think that we do have a responsibility to say, okay, well, when we are getting into a trial or a study, that we are trying to find ways to make these trials similar, and to have expectations that researchers say, okay, these are the standards by which you should look at BPH therapies, so that we can answer exactly those questions that patients ask. And quite frankly, it's what urologists want to know, right? They want to know, if they have patient X who has a prostate that looks like this, what are my options and what are the right ones? I wanted to take this moment, because we were talking about the pivotal studies here, that they all are a little bit different, but the legacy technologies was new in this last guideline, which we don't have new data on them, so it's harder to put it into the context of some of the new technologies coming out there, but the technologies themselves are not unsafe. We just don't have anything that met our criteria for inclusion in the guidelines, so we have now called those legacy technologies. So that is a new term for us within the BPH guidelines. So we're going to go back to that. Dr. Mandeville, so when we're talking about published trials and randomized control trials, how HoLEP enucleation is the most studied of basically all the technologies, even TURP to a large degree, but TURP is often used as the comparator. So knowing that, you're an expert in this area that has such robust information, and sometimes a little bit conflicting based on experience, how do these RCTs and clinical trials, affect your decision making, and do they matter to you?
I think, well, they're important, first of all, because patients are smart, and patients have access to the world at their fingertips on Google. And so many patients come in and they've read these academic papers, and they know. So you have to know as well, because if they come in knowing more than you, you're not looking great. And then number two, I think it's important. I mean, it's shaped my practice as far as urodynamics, right? I stopped doing urodynamics on the suspected hypotonic bladders based on the literature out there that shows that these patients are going to void regardless. It also helps me guide them about, reintervention rates, because there's pretty well documented reintervention rates for TURP and HOLEP. And it also keeps me on my toes to make sure that my numbers seem to stack up with what's out there in the reported trials. So I will go through with patients what the literature suggests that the retreatment rate for HOLEP is, which is extraordinarily low, and then I'll tell them what mine is, which is low. And then I'll go through them with what the literature reports as transient incontinence and permanent incontinence and what I see in my own practice. And so I think it is important. I think it's important to tell people what the data shows that's out in the literature, but also what you have in comparison to what that data shows. And also to be able to compare other technologies, because now everyone comes in and they say, well, I'm here to talk to you about HOLEP, but also aquablation, but also robotic simple prostatectomy. And I want you to talk to me about all three of them and what the differences are and what the outcomes are. So people are smart, and you need to know, and you need to be able to talk intelligently about it with these very, very smart patients.
The last question, Dr. Teo, I'm going to put to you before we go into talking about each of them, because you also have the unique perspective as being trained in oncology. And in oncology, I feel like the trials are designed in a much more specific way, that it's pretty strict. You are going to follow these bladder cancer guidelines. You are going to do this. This is what we recommend in prostate. It's much more prescriptive than what it is in BPH. Do you find that it affects what you offer patients, having, sort of a training towards a very specific set of guidelines?
Well, I think it can be quite different, treating BPH versus bladder cancer patient. But I think that's the fun part about BPH as well, right? There are so many different factors that you need to consider, trial data, but also the actual real world evidence. And most of the time, patients do have an option, right? Yeah. They can actually choose what they want to do based on the recovery process as well as the long-term efficacy. So I think it's actually quite okay for me, to take these things into context and actually offer an option, which they actually choose for themselves in a way, what they want to do in the future.
That's actually a great point. I hadn't thought about that, because in oncology, we often tell them this is where you're going to go. And so it probably is somewhat refreshing to have them as part of that decision making and having them make a choice. So that's a very interesting perspective. So thank you for joining us today. Again, thank you to the faculty members, and get on it over to the AUA University.